Good morning, everybody. It's a real pleasure to be here today. I'm Anne Cooper, the Chief Nurse at NHS Digital, but actually I'm not really going to talk about NHS Digital today. So if anybody does want to speak to me about NHS Digital, you'll be able to find me on the Digital Citizen Zone at lunchtime and later on today. I want to present a different perspective today. Which is a very personal perspective. And it's great following David, actually, because I'm not going to talk about regulation, which would be one of the things that I was normally expected to talk about. So where were you in 1979? Sometimes when I ask this question, people in the room weren't even born in 1979. I guess that some of you, like me, I left school in 1979. I can remember ABBA, Sister Sledge. I remember Margaret Thatcher, the first woman Prime Minister. But it was also the year that I was diagnosed as having type 1 diabetes. Back then, it was a very interesting time to be diagnosed because we were still using test tubes to test wee as a way of testing our control. We had no computers, of course, then. We had no smartphones. We had very little in the way of technology. We didn't even have testing kits and things that we have now, the little machines. It was very, very different to the way it is today. Now I've got a smartphone in my pocket that people tell me is strong enough, is the equivalent of what was used to power the Apollo space mission. And that means that today we have the potential to do something very, very different, to look after people and help them to stay safe and independent. And also for me, have a much more liberated lifestyle. So I want to talk to you about two things. I want to talk to you about wisdom, and I want to talk to you about empathy. That's what self-management means to me today. So on the left-hand side, you've got the stuff that generally I'm expected to carry around with me. On the right-hand side, you've got the stuff that I keep next to my bed, and there's loads of little sticks in that sparkly bag. Each one of those represents a time that I've tested my blood glucose. So, you know, it's still quite difficult, even when we've got technology to help us to do things. People often recommend to me that I use an app or something, a diary, that I enter data into it, that will make things better. But actually, I've never managed to do that. And I've often wondered whether that's because I'm a technology laggard, or whether in health terms I might be considered to be somebody who's non-compliant, which I think is the most terrible label to apply to anybody. Or am I just a late adopter? So I think I've struggled hard with this because I try very hard to be a good patient, a good citizen, somebody who is responsible for my own health and care. And as I've matured in my professional role, I've started to spend more time in the technology space. I've spent the last 10 years working in what would traditionally be called health informatics. And I've reflected more recently that actually it may not be me that's the problem. It may be the tools and solutions that are the problem. So when people have a good idea about what they want to provide me, and when they talk about the things that I should and shouldn't do, I think it's quite important that we think about where that's coming from and what drives some of those conversations and those solutions. And I think we need wisdom, and we need a greater degree of empathy and wisdom in order to create an environment where we can do this well. So the first thing is user experience. I think this is a really difficult thing to crack. And when at work, I work with people who are designing solutions and they talk about doing user research. For me, that's just not enough. So the thing about going out there and talking to people about what they might want is not, for me, user experience, nor is it good UX design. We need to get much, much closer to people to be able to understand those things. So I was heartened to hear a lot of strands running through the other speakers this morning about people's experiences. The only way that we're going to get this right for somebody like me is to bring us into the room with the people who are creating the solutions. That's up close and personal. So that's the first thing, the first piece of wisdom. The second is what's called utility. I think for a long, long time, people for me in the diabetes space have created solutions that they think are a solution to my problem, but they've never really asked me what my problem is. And I think if you think about it, I've got an insulin pump clipped to the front of my bra here. I've got in my bag over there, I've got testing kit. And yet people are still expecting me to double entry results into a diary that's not connected. Stephen talked about connectivity. It's really important for users, for people like me, that things are connected to each other. So that's about utility. That's about trying to get into what it is that people really need to help them to live healthy and happy and useful lives. So we shouldn't impose what we think our good idea is on those people. Sometimes people design useful solutions. My insulin pump is really useful. It's got an alarm function, but it doesn't always alarm when I want it to. So I've been speaking at conferences before where it's been beeping like crazy. And that's not a utility product for me when I haven't got the ability to change that or get to it easily or do something about it. Sometimes people create solutions that are just more admin and overhead for me. People who have long-term conditions have a high... I spend quite a lot of time woven through my day looking after myself. I did a blood test when I was sat down at the front earlier and then had to eat some jelly babies because I was a little bit low. That's an overhead that has to run through the way we do things every single day. We don't want products that add to that overhead. We want products that actually enhance our lives. So you've got to be clear about the problem that you're trying to fix. And you've got to be clear about who you're trying to solve that problem for. If I'm not testing my blood glucose frequently enough, is that your problem or is that my problem? And if it's both yours and my problem, bring us both into the room together and we can talk about it together. So be wise. Be wise about how you create solutions for everybody. And I'm not just talking about relatively well people like me. I'm talking about elderly patients. I'm talking about people like Alison's dad. We need them in the room and we need to work out how we're going to do this together. Build in quality from the start by bringing those people with you right from the very beginning. So my thinking about this over the last year or so has brought me on to thinking about empathy. Empathy in technology is not a word that we normally use. It's not something that when I'm talking to the technicians back at base, it's not a word that they would really understand as part of what we need to do. But I think it's a really important word. In marketing terms, we talk about delighting customers. And they talk about if you can actually get to the point of delighting customers, like the Apple products, arguably, for example, actually you see accelerated adoption. And we need more adoption in health technology for people to be more self-sustaining and more self-sufficient. So how can we use empathy to move to the point of people's delight in the products that we use? I think using empathy, it brings us closer to the people who are going to use products. So designing in great functionality requires empathy. If you're actually going to do what I've been suggesting, you need to get closer and you need to behave in a much more empathetic way. But that's quite scary, and actually it's really quite difficult. So I've actually started thinking that we need to use co-production as a principle in the way that we design technology. And Mark, who spoke earlier this morning, he wrote a blog recently, Mark's in the audience somewhere, about what we mean by co-production. We don't mean consulting, we mean in the room together working out what we need to do. So we need actually people to drive the digital revolution. For me, uninvited guests demonstrates how you can design something that's actually quite clever, but do it with a lack of empathy, with a lack of understanding or insight into that gentleman and what was going to help him resolve his problems rather than the perceived problems of the family, I think. And I think there's learning in that for all of us. So I think empathy is a really important principle for us to think about in the environment that you're all and I'm working in. And the TSA white paper points us to the opportunity that we have. The other speakers have alluded to this, which is that as we're reaching the point where we're facing substantial change, a very positive thing that we can do from my perspective is to try to ensure that we get people to help us to design what they want us to use, rather than allowing ourselves to assume that we know the answer. So thank you very much. If you'd like to tweet me and talk to me about this, I'm very happy. My handle's on there. Thanks.
We've heard a couple of a lot this morning about the need to develop evidence base for what we're looking at and the efficacy of the digital services that are on offer. But we've equally heard the need for that evidence base to chime with individuals and their lived experience. And often that lives to a sort of dissonance between the professional requirements and requirements of the general public. And particularly, I think, in relation to health services and I'm thinking here around the discussion around evidence-based and that sort of epidemiological gold standard needs to be required to do almost anything, it seems. But you've seen there in that video that actually that sort of evidence base doesn't necessarily chime with that individual's life experience. Can you sort of give your thoughts on how we overcome that? Because it seems to me that there's a potential major barrier there in reconciling those two things.
So I'm going to start with Stephen, but I think that balance between innovation and evidence-based and evidence-informed.
I think you've put your finger on an issue that the health and care community often talk about but haven't really thought through. It's all tied up in the word outcome, isn't it? What's the outcome we're looking for? Is it an outcome that satisfies the scientists, or is it an outcome that the citizen wants for themselves? And the truth is, I absolutely agree with what Sue said about the importance of engaging the citizen in the choices that are made about the care package that is provided. It's an awful phrase, but co-produced means that it's not done to the citizen, it's done with the citizen, and the citizen's engagement in the package of services is absolutely key, in my view, to the delivery of a service that I would want for myself and for my family. And that includes the freedom to make decisions which the clinician may conclude lead to a suboptimal scientific outcome. Now, how you tie all that into a proper understanding of outcomes and then use that evidence to do as I described, make the care system accountable for the outcomes it achieves, I don't have an easy answer to the conundrum you pose, but it's one of the issues that needs to be more fully debated, more fully understood, rather than simply glibly saying what we need is a system that delivers better outcomes. What do we mean by that phrase, better outcomes?
Thank you. David?
I hope I've understood your question. I think this picked up something like 9 out of 10 innovations fail. So for every one that you're going to get that is going to go to scale and to go to market and be a commercially viable product, there'll be 9 left on a floor somewhere of things that didn't quite get there and didn't quite work. And so I think that goes right to the heart, as Stephen's already pulled out about, so what is the evidence base for this? If you were always looking for randomized control trials as the only way of doing things, we'd be waiting for a very, very long time. What is it, from the weekend, Saturdays Today programme, Sally Davis, the Chief Medical Officer, on new antibiotics. It's 30 years from the breakthrough in the lab to it being a commercial product and being available. So that's the opposite end of this is going to get done very quickly and to scale. So somewhere we need to find a space between randomized control trials as being the only acceptable evidence and things which are good enough to start. But there's some tricky stuff there. We came across a case of a guy in Scotland who, using a digital access, got onto a system where he was prescribed some pretty heavy opiate-based medication, was given this, and it reacted badly with what he'd already taken. He was somebody that misused substances, and he died as a consequence. So I think caveat emptor, buyer beware, this is a commercial thing and you can make your own decisions. it was his own money to a private company, normally we'd say caveat emptor is fine. So I think there's some really tricky issues between your randomised control trials and caveat emptor as being the way to do this. Some of the apps that we're actually dealing with are 16-year-olds in bedrooms who are developing apps that they then sell for millions and millions of pounds. Well, how the hell do you regulate that? I don't even think you try to start regulating the development of the apps in that sense. I think it's got to be about the treatment people get as a consequence of going through. And this is, I think, where I'd begin to elide my points with what Stephen has said. I really loved Anne's presentation in relation to empathy and that issue about make it work for the user. So my father died earlier this summer. He was 86. He began to use technology. So I was walking on Ashdown Forest one Sunday afternoon, Facebooking him, not Facebook, FaceTime. And the only reason we were doing this is he was trying to work out how to use the phone. But the point being is that he was connected in a way, and that was something that worked for him. It happened to work for me as well. And I think this point, so I taxed my car, and I did that on a Sunday evening. I'm not making an advert here, but I went to see a lifelong friend who now lives in Spain, flew by EasyJet. And I have to say that EasyJet app is about as simple and as easy as something that you can use. And its utility to me, its empathy, because it's obviously designed around people using services, was just fantastic. So I think there are some gold standards out there. And I don't think we needed a whole bunch of evidence from EasyJet about that, because most of us would complain about queuing too long and why does it cost £4 for a coffee when you're on EasyJet. But actually, as a way of actually travelling, getting to the station, it had all the kind of utility. So I think there is a really, really important conversation, and this goes back to my key point, which is commissioners and providers, those of you that work in these services and people using services need to be involved in the conversation alongside regulators. But regulation can't dominate that discussion.
Other airlines are available, just to be absolutely clear. Anne.
I think I'm a nurse, so yeah, it's on now. I'm a nurse, so obviously I come from an evidence-based profession, and I think clinical evidence is a really important thing. But I do think that what we have to be is quite open-minded about what the most appropriate type of evidence is for a particular thing, which is a little bit about what you were saying, really. So, and I'm quite intrigued by the notion of value and how we measure value and how we include stories from people about what value is. You know, I've been on lots of big national programme boards where benefits are managed by money, and we have to look for savings, and everything's got financial stuff attached to it. We have to do that. We've got to be able to be held to account for what we do. But there are other things that we can do, and it's choosing the right thing, I think, at the right time to provide the right evidence for what we're trying to achieve.
So I'm just going to go back to the audience for one more opportunity to ask a question. I think I can see a hand with a pen in it waving at me, so there's a microphone coming to you, and I think we'll have this as our last question.
Sorry if this is a bit sort of esoteric, but I was struck by the video, so thank you for sharing that. For me, there's something about the focus of concern for this endeavour. Are we enabling people to live joyful lives, or are we enabling them to endure an efficient care system? And so for me, I accept that life is a continuum of increasing entropy. So I think we should be talking and educating people to navigate, enjoy, accept and celebrate that journey. And towards the end of it, it's more about enjoyment than being longevity. And I just want us not to fix a problem that really isn't there and to create solutions for people to live. That's it.
Okay, I think a very apt challenge, which echoes some of the points that have been made already. But I'll just ask for maybe one last reflection on this, and also possibly from the point of view of the sector that you represent, the interest that you represent, whether it's regulation or whether it's from the point of view of the role of NHS Digital or the role of the Confederation. It'd be interesting to get, how do we take systems that are built around the delivery of services and very clear outcomes from a clinical perspective, from a care perspective, and enable them to change to become things that are about fulfilling people's aspirations to have the life they want to lead. I think that's a real challenge and conundrum which this sector is keen to be a part of as well. But I'm going to start the other way around. Just last reflections on that point from.
It's a really interesting point that you make. I think for me this is about power and where power resides in systems. And I think it's time for us to start shifting some of the power back to the people who we're trying to create solutions for. And that's a really big ask, and it's a real challenge for everybody in the system. It's a real challenge for healthcare professionals who've traditionally had the power in the system to determine what happened next. And I think it's time for us to reflect. It's a very big thing that I'm asking for, I think, but for us trying to reflect about where power sits in the system.
Very briefly, digital for me is a means to an end. It's not an end in itself, and I'm slightly worried when I think there's conversations going on where digital becomes the end in itself. And I completely agree with your proposal that this should be about enabling people to enjoy their lives to the maximum that they're able to do, and therefore technology that helps people to do that has a utility and an empathy, to use Anne's earlier comment, I think is going to be hugely successful. I think the end that we're trying to get to is personalised health and care, which is personalised around each individual that helps them live the life that they can. And that's going to be about the provision of information or just the provision of services. You know, it may well be by the time I'm 80, there will be a robot that will do the hoovering. And, you know, if it's there, then, you know, I don't know. If I'm not sending the neighbour out with a walking stick with a kind of red stripe to do that, I might use the hoover. But I'm absolutely with you on this should be about personalised health and care, and technology should be helping the personalisation of that health and care.
I think we're all in violent agreement, actually, on this subject, which is that digital technology is a means to an end, but it's actually, the end is reshaping the services so that they respond to the people who use them. It's the question that I quite often quote from Lenin. It's not every Tory politician that quotes Lenin repeatedly, but it's a very simple way of putting it. Who, whom? And in the traditional model of service, the who is the state and the system manager, whom is the person who gets what they're given. Technology allows us the opportunity to rebalance the who, whom question.
Great way to conclude this session. Thank you. Can you show your appreciation to our three speakers for excellent presentations? And can I just say that we are now going to break for lunch, time for in the exhibition area, and then after lunch we have a breakout session starting at 2 o'clock. So enjoy lunch and going around the exhibition. Thank you very much.